Thank you all for attending this talk. I will be presenting this joint work with colleagues Nikita, Panos, Anne, and Nigel, entitled COVID-19 and Domiciliary Care Utilization, Evidence from the English Longitudinal Study of Aging. By now, this work has been published in the Journal of the Economics of Aging, so in case you're interested in details, it's available online. The usual disclaimer applies. So we are living in the era of an aging population, and among other things, this highlights the importance of access to social care. In this study, we focus on domiciliary or home care in particular as a crucial element of social care, which plays a key role in ensuring that older adults who often have to deal with multiple physical and mental health conditions can live as independently as possible with good levels of life satisfaction and well-being. And this importance of home care was felt even more acutely, perhaps, during the COVID-19 pandemic, which led to substantial disruption to all kinds of health and care services, including both formal or paid home care and informal care, typically provided by family and friends. And while aiming to protect the most vulnerable population groups, COVID-related policies oftentimes resulted in access to this vital form of care for those most reliant on it becoming very limited. So our overarching aim was to understand how the COVID-19 pandemic affected home care use of various groups of adults over 50 in England. More specifically, we looked at how the pandemic changed the likelihood of receiving care, which we refer to as extensive margin change, and how it impacted the amount of care received given that someone was accessing home care during the pandemic. This we refer to as intensive margin change. Next, we analyze how well the care received met respondents' needs before and during the pandemic. And finally, we investigate whether displacement of domiciliary care use had similar patterns in the healthcare use domain. We mostly look at some acute and primary care use indicators. So this slide summarizes our findings. So if you need to leave soon, these are the take-home messages. First, we find that the pandemic led to a reduction in the likelihood of accessing home care, mostly driven by informal care use. However, we found that those individuals who reported having received some care during the pandemic, on average, were reporting that they were receiving more care than before the pandemic. Importantly, we find that some groups were affected more than others, and among those who were reporting an increase in unmet need, we saw that ethnic minorities, those not in work or retirement, and those with musculoskeletal and mental health conditions were among the most negatively affected. And finally, we find that there is a substantial overlap between the groups who were negatively impacted in terms of home care use and healthcare use, with the exception of the age domain. So we conduct our analysis using 3 waves of the English longitudinal study of aging, specifically wave 9, the fieldwork for which was conducted, if I'm not mistaken, from June 2018 to July 2019, so before the pandemic. And this is where we get not only the pre-pandemic outcome variables, but also a large number of respondent socio-demographic characteristics and health status indicators. And we also use the 2 COVID waves of the survey, which were conducted in June-July 2020, that's COVID wave 1, and November-December 2020, that's COVID wave 2. Those modules do not include the full set of questions asked in the waves prior to the pandemic, but they do have information on our outcomes of interest, allowing us to compare the before with the after. So we have several outcome variables. The first is whether individuals were using any type of home care. So they could have been using informal care only, formal care only, both types of care, or none at all. This is measured for both pandemic and pre-pandemic periods. And I think the question goes something like, in the past X days or weeks, it depends sometimes on the wave, have you been using this type of care? In wave 9, it's slightly different questions, but I'm not going to get into the details at the moment. We can maybe talk about it later. So the second one is about the amount of care received, and it is only measured in the COVID modules and for individuals who were receiving some form of care in the pandemic period. They were asked something along the lines of, oh, you answered that you were receiving care at home. How does it compare to the amount you were receiving before the pandemic? So the options were more than before, about the same, or less than before. Yes, so we also, the third outcome that we're looking at is the variable around how well home care was meeting respondents' needs before and during the pandemic. The options here were all the time or usually, which we consider as needs are reasonably met, sometimes or hardly ever, which we consider as needs not met or not very well met. And also if respondent had no care needs and previous two options were not applicable, they could report no care needs. And the second block of variables is on healthcare utilization. Specifically, we use information on whether an individual had a cancellation or of a treatment or procedure. This question is only asked in the pandemic waves. And finally, we analyze changes in primary care used during the pandemic based on the question which asks whether an individual used GP services in 30 days prior to the survey. And as usual, we use this wide range of control variables such as age, sex, health conditions, job classification, employment status, number of household members, income quintile, ethnic group, and region of residence. Now, let's have a quick look at the raw averages of our outcome and control variables. We have roughly 5,000 individuals observed through 3 waves, which makes it about 15,000 observations. If we look at how the proportion of individuals using home care changed, and this is what's in the slide now, no model is really needed to see that it decreased, and largely due to a drop in informal care use, which is relied on by the individuals more than formal care. However, among those who did receive care in the pandemic period, most report no change in the amount of care received, and quite a few also report an increase. And when we look at how well care needs are met, from the first glance, it seems that more individuals report unmet need, but more individuals also report needs being met. And this is because in the pandemic period, more individuals reported having care needs at all. So what we do is we analyze not the raw likelihood of reporting unmet need and how it changed, but rather the relative risk, that is the likelihood of reporting unmet need given that the person has care needs. And finally, we can see that, for example, in the first COVID wave, about 17% of respondents reported a procedure treatment cancel. That's quite a lot. And much fewer individuals were also able to access primary care as compared to the pre-pandemic period. So, and here are some proportions of individuals belonging to certain socio-demographic groups, which are representative of the English populations of individuals over 50 years old, as we are using weights. Respondents are more likely to belong to younger age groups and are mostly retired, but quite a lot, about 35% still in work. 23% live alone, 7% belong to minority ethnic groups, and about 36% have a musculoskeletal condition, and some other prevalent conditions are respiratory, ophthalmic, and mental health. So I have these slides on methods and models, which we will skip in case someone has questions, geeky questions. I can bring the slides back, but let's just jump into results. So our first question was about how the pandemic changed the likelihood of using different types of home care. This graph depicts the changes in the probabilities of using formal and or informal care for each socio-demographic characteristic. So these are adjusted. The dark blue color means that the change is statistically significantly different from 0. And the bars are confidence intervals reflecting how precisely these changes are estimated. So the smaller this interval, the better, the more precisely we're able to estimate the effect. Immediately, we see that the most affected domain for almost all groups was informal care, and also declines were seen in probability of using both types of care. Formal care doesn't seem to be affected that much. As you see, there are almost no significant effects, but this might be because individuals were generally, the proportion of people relying solely on formal care was quite low, both before and during the pandemic. And from here, also, if you look at the left panel, it emerges that the most affected groups were ethnic minorities, those of these other employment status, where we grouped together the unemployed individuals, those looking after home or family, and permanently sick or disabled individuals, and those with a mental health condition. For them, the changes in likelihood amount for about 9 to 10 percentage points for these groups. Now let's look at the intensive margin results. We have seen in the raw data that most people who received some home care during the pandemic reported either no change or even an increase in the amount of care received. And this is also true for most socio-demographic groups. For example, among those most affected, in the previous slide, we saw that there were people with a mental health condition, but actually they were likely to report more care received if they were receiving care. So for a group as a whole, this may have counteracted to some extent the negative extensive margin effect. But for some other groups, both effects were going in the same direction and were negative. These groups include ethnic minorities, those not in work or retirement, employees, and those living alone. And finally, we found that older individuals who were recipients of home care during the pandemic were more likely to report an increase in care received than their younger counterparts. So now we've looked at the likelihood of using home care and the amount of care used, but since for many groups the effects go in different directions, for some the same directions, the impact on unmet need might go either way. So when we analyze unmet need, we indeed actually find that for many groups, there has been no change in unmet need, but for quite a few other groups, the relative risk of reporting unmet need went up. Those were, yet again, ethnic minorities and those not in work or retirement, which makes sense as we saw that both these groups were negatively affected, both at extensive and intensive margins. And among other groups, the younger individuals, aged 50 to 59, those living in single-person households, those with a routine or manual occupation, and those with a mental health, ophthalmic, or musculoskeletal condition were among the most affected in terms of the relative risk of reporting unmet need. And an interesting exception were employed individuals. They saw no change in the relative risk of reporting unmet need, despite negative impacts at both margins. This could be because their level of need and perhaps the complexity of need is lower than that of other individuals, and this is why they're able to stay in work in the first place. And finally, we examine whether similar patterns were observed for healthcare use. Almost all groups reported a cancellation of a treatment or procedure in the pandemic period, especially older individuals and those with pre-existing health conditions. And when we looked at access to GP services, the most affected groups were yet again ethnic minorities, those who were older than 70 years old, those with a musculoskeletal or respiratory condition, employees, and those living in multiple persons households. So if we try to pool all the findings together, we can say that first, unsurprisingly, perhaps the pandemic led to an increase in care needs, since there were all these lockdown policies, isolations, shielding, etc. So perhaps if a person even were able to go out and do their groceries by themselves, they could not leave their home anymore. So naturally, needs went up. And also, of course, when healthcare services were less available, definitely that resulted in an increase in need that wasn't met. But precisely because of these COVID-related measures, providing care, and in particular informal care, became much harder. And as a result, we saw a drop in access to home care and a rise in unmet need on average. So as regards the most affected group, one group that really stands out is the ethnic minorities, and they saw negative changes across all domains we looked at: home care, primary care, both margins of home care unmet needs. So wherever we looked at, ethnic minorities were negatively affected. Another quite vulnerable group are individuals not in work due to sickness or disability, the unemployed, and those looking after home or family. And finally, those with certain health conditions, in particular musculoskeletal, were also negatively impacted across a range of domains. So with age, we actually saw a mixed picture, as older individuals appeared to be less affected in terms of home care, but more affected in terms of healthcare use, while the exact opposite was the same for younger individuals. And overall, while pandemic policies were designed to protect vulnerable people, they also made it harder for many to access essential care, thereby increasing unmet need and potentially deepening existing inequalities. So perhaps that's the findings of this study could be used to think of how we should, which areas perhaps we should target in case of future adverse events such as pandemics. I think that brings me to the end of the presentation, and take your questions.
Thank you, Anastasia. Any questions from the audience? Raphael, please.
Yeah, thank you very much for a really interesting presentation. Can I just ask about access to GP services or primary care? Was that defined in terms of face-to-face consultations, or any consultation, including phone and Zoom and so on?
It was just any type of contact without specifying if it was remote or face-to-face, what we were able to capture. So we're not able to distinguish face-to-face versus remote.
Yeah, thank you for clarifying.
There's a question from Emma. Is there a plan to follow this up for the post-pandemic period in terms of pattern of home care use?
So you mean to check the future waves of the ELSA survey and to do similar analysis? Is this what you mean?
Sorry, because I just think it will. The pandemic is a very exceptional period, so I was just thinking it would be interesting to see, has it continued to worsen on that trajectory post-pandemic?
Right. I don't know if it's a politically correct answer. Anna's here to help me. I guess if we're funded, we could. So this project has concluded. I guess if there is interest, we could continue working on it and put a respective proposal.
Sure. Well, I'm at NIHR, so you can reach out.
Okay. That's good to know. Thanks.
Yes, and a follow-up on Emma's point, I think it is always useful to investigate. Probably it is intriguing to investigate to what extent the COVID-19 has permanently changed the pattern of use, or whether after COVID-19 the pattern of home care use switch back to its pre-pandemic level. Okay, so Mark, you please.
Thank you. Yeah, thank you both. My kind of question follows on from that, really, and thank you. Really interesting, Anastasia. Thank you. I'm a PhD student, and I'm looking at the transition of care home residents to and from the emergency department. And part of the data I collected, emergency department staff were talking about how relatives became more invested in their older relatives' health and care during the pandemic and really took ownership of that responsibility. And so it'd be interesting to know whether that level of interest and support was continued post-pandemic. Yeah, I guess I'm more qualitative and just thinking about the how and why and those kind of things, but it's really interesting to kind of look at that data. Thank you.
Yes, I guess you're referring to a slightly different data from what we have been using in this study. I don't recall anything that could perhaps let us, pin down what you just mentioned. But if there is such data, I think that's definitely worth investigating. Would be of great interest. Yeah.
Thank you.
Yeah. So one other question I have, Anastasia, this is really interesting to see you report those findings, and you talk about that there's a notable decrease in terms of extensive margin of receiving informal care in the during the pandemic. I wonder to what whether you have been able to, in the process of your data analysis, to distinguish between those who receive extra residential care and co-residential care, presumably because of the lockdown of COVID-19. Those people relying very much on extra residential care, they have the most difficulty in terms of access informal care, whereas for people relying on co-residential care, that is, they receive care from people living in the same household, that might not be affected that badly. That is whether, to what extent the decrease in informal care is driven by extra residential care or co-residential care.
That's a very interesting question. I don't have a ready-to-go answer for that. The closest we got to this question would be to look at how individuals, how different household arrangements were, how effects differed by different household arrangements. So people living alone, they did see quite a substantial drop, more so than people living in 2-person or 3-person households. So I guess to some extent that relates to a question. I understand it doesn't fully answer that, but I guess that's the closest we were able to get to it. So yeah, I would say that people relying on help from outside of the household were in fact affected negatively.
And related to that, whether in terms of unmet needs, it is also people living alone, they are more badly affected compared to those who live with someone else in the household.
Yes. So did you ask if that was the case, or
whether you have been able to look at that, there's differences? Because I think the reason of raising this is that for people relying on informal care, the risk they face during pandemic are different. It very much depends upon their living arrangement.
Yes, that's correct. So in terms of unmet need, we did see that the relative risk of reporting unmet need increased for those living alone, but it didn't change much for, there was no statistically significant change for those who lived in 2-person household or 3-person household.
Okay, thank you. That's really interesting.